He's been the focal point of the coronavirus response in Henrico and Richmond as director of that health district, helping residents navigate their fears and hardships. Dr. Danny Avula joins me now live via Zoom with where we go from here. Doctor, thanks for joining us in this new technological world we're in.
My pleasure, Bill. How are you?
So we're going to talk a lot about testing, and obviously for reopening, the issue of the day that everybody wants to know about, we'll be talking a lot about that. But a respected model from the University of Washington suggests Virginia has hit its peak of new cases. Have we? And could we actually know that without more widespread testing?
Yeah, I don't think there's any chance that we've hit our peak of new cases. And that's largely a result of the fact that we have not had significant access to testing. It's getting better. It's getting better every week. But I fully expect in the weeks to come, as we expand our testing capacity even more, that case count is going to continue to rise and rise. We're going to find more cases. I expect the delta, the daily number of cases, to rise each day in this near term. Other models we've looked at, the University of Virginia one in particular was predicting a peak of more like the middle of August. There's a couple of other models around the country that all have different factors, right? There's assumptions that are baked into each of these models. But I'm almost certain that we have not yet reached our peak, and that as we expand our testing capacity, we'll continue to see a significant increase in cases here in Virginia.
So the governor talked about reopening, which is on everybody's mind pretty much every day. If we start in 2 weeks, like he said, is 10,000 tests a day enough in a state of 8.6 million?
I think it could be, definitely more widespread access to testing is what's needed. And that doesn't mean that every single person has to be tested. What it means is that when we suspect that somebody is ill, we've got to be able to have rapid access to test them, and then to do our contact tracing, and then to test any contacts who may have developed symptoms or that we may be concerned about. So I think, quadrupling our current capacity will help us do our effective public health intervention of case contact tracing much more effectively.
Well, so we won't get to a point then where we test people beyond those that present symptoms? Because isn't it that we need widespread, randomized, regular testing to know really where the disease is?
Yeah, I think we will get to a point where we need to test beyond just symptomatic, because that's kind of where we are now. And particularly as we think about who the most vulnerable residents of our community are, when we think about the residents of our nursing homes and assisted living facilities, or hospitalized patients, or the elderly who live in community but may have multi-generational households, we're going to need to get to a point where we can regularly test, let's say, healthcare workers of a nursing home. I would ideally like to get to a place where we can test them almost on a daily basis or on a cyclical basis to make sure that they're not unknowingly bringing this disease into nursing homes.
Well, I know there's already a lot of Monday morning quarterbacking going on, at least at the federal level, and the response there. As you look back to how we responded here, both in the state and locally in Henrico and Richmond, particularly with the nursing homes that you mentioned, it seems like the cases began a whole lot earlier. We're hearing reports today that in California it began 3 or 4 weeks earlier, possibly in New York a month earlier than the first cases that had been reported. In that case, it could have been here long before we would have had time to sort of close off the nursing homes and protect those people inside.
Yeah, I think that's absolutely possible. I mean, even with the first really significant outbreak we had here with Canterbury Rehab, where, their case was confirmed the second week of March. Likely they were having symptomatic individuals that first week of March, but it's very possible that we had cases even back in February that just weren't on the radar for folks. And I think that, as we look back on this, I think at every step of the way, we will say, could we and should we have acted earlier? And it's so hard to say. I mean, I think obviously every one of us would say, yes, we should have, sure. But knowing, having the limited information we did at that point, it was really, I don't know that we could have put things into motion any quicker than we did here.
Where does the responsibility for testing lie? Is it local facilities coming up with their own tests? Is it the state? Is it the federal government? Because, for example, you look at Germany deploying widespread antibody testing to see, hey, can I go back to work? I've got the stamp of approval. I may have some immunity here. How far away are we from that? And again, who is responsible to get that streamlined system out there?
Sure. So there are a number of antibody tests that are being used and tested in different places across the country, a number of clinical trials that are going on to figure out what is the utility of antibody testing and what does it actually tell us. When you find that you've had antibodies, does that mean that you actually have protection now? And if so, how long does that protection last? I think there's a lot of big questions globally that we're trying to figure out of what does it mean that you have developed antibodies against COVID-19. Where does the responsibility lie? I think without a doubt, this had to be a federal government directive to early on say, we're going to reorient the way that our funding is being directed, that we're really going to prioritize testing access, that we're going to address the supply chains. You've probably heard a lot about the fact that testing requires a number of different steps. It's not just the machine in the lab, but it's the reagents and the staff required to run that machine. And then on the ground, it's the sterile Q-tips, these long swabs that are required to actually get a good respiratory sample. And then those have to go in a particular viral transport media so that they can be safely taken to the lab to get an accurate result. And there's so many different pieces of the chain, and that had to really be driven at the federal level to make sure that all of those supply chains were opened up and in line, so that and if that had been done earlier, we'd be in a very different place than we are right now as it relates to testing.
Yesterday, the Virginia Hospital Association asked Governor Northam to relax the ban on elective surgery. So are you satisfied that hospitals and health facilities in your district have all the PPE they need? It seems like ventilators not necessarily an issue. So if the hospitals have what they need, what is the drawback to opening that revenue stream? Because hospitals are getting crushed, tens of millions, in some cases, hundreds of millions of dollars in losses already.
Yeah, I mean, your point about ventilator usage is an important one, because it means that what Virginians have been doing, what folks here in the Richmond area have been doing is actually working. Our hospital systems are not overwhelmed currently. There's plenty of hospital bed capacity. Our ventilator usage here in Central Virginia hovers between 25 and 30%. And so the efforts are working. We're maintaining the healthcare capacity that we were hoping to maintain. But what we'll see as we start this phased reopening and reentry into society is that it's gonna put a strain on the health system, and we've got to figure out what's the right degree to open that faucet. If you open it too much, the hospital systems are going to be overwhelmed, but it's really hard to figure out what's the right amount to open it, because we don't at this point have really good data that says, hey, if we reopen schools, that will increase hospitalization by 10%, or if we reopen restaurants, that might increase it by 20%. We don't have those types of numbers yet, though that would be extraordinarily helpful into us determining the prioritization of a phased approach.
Dr. Danny Avula, we thank you for your candor and your availability in answering pretty much every question that we and anyone else might have in this situation. And again, thank you for taking the time tonight.
My pleasure. Take care.
All right.